Hi, everybody. So the update today from UAB on coronavirus is we still do not have any confirmed cases in the state of Alabama. There are over 1,000 cases that are confirmed in the United States, 29 deaths, and there's cases reported in 38 states. So we do still think it's probably a matter of time until we see cases here in Alabama, but we don't have any yet. A lot of the messaging that is important now is related to social distancing and really making sure that people who are symptomatic let someone know right away about their symptoms, but try to avoid exposing other people at work, at school, in the community to their symptoms when they have them. There will be someone who will speak next about campus decision making, so I can't speak to that, but I'm happy to take your questions about coronavirus here at UAB and how we're managing it.
Is it true that someone who may have been exposed to someone with coronavirus and may have it but not show symptoms of it still be able to transmit it to another person?
It's a good question. So in infectious disease, we like to know that very much. What you're talking about is the incubation period. How much time is it between being exposed to someone with coronavirus and having symptoms yourself? It's about 5 days. So in those 5 days, the virus is increasing in levels in your body, but you feel fine until the 5th day when you have the typical fever, cough, difficulty breathing. There is some new data that maybe people can transmit the virus before the symptoms start, and that's a big concern for us. Most of the studies are showing that the transmission is happening from symptomatic people. So it looks like most of the virus and most of the transmission is not before but after symptoms start. That's why we're focusing so much on people who have symptoms, saying if you have symptoms, don't go to work, don't send your child to school if they're symptomatic, that type of messaging.
And is there a shortage of test kits? Do we know how many test kits we have in the state right now?
So the testing is all being run through the Alabama Department of Health and with the CDCs. There's testing available in every state and in Alabama, obviously, too. The testing is being prioritized for people who meet certain criteria, either known exposure to a case, known travel to an area where there's coronavirus, or someone who's sick with typical flu-like symptoms. Patients are being encouraged to call providers, and providers are the ones who have to recommend this test. All the algorithm is based on that. So it's available. I think all of us would like to have more testing available more quickly so we can have a sense of patients in the hospital, whether or not we're seeing coronavirus and not recognizing it. The system is ramping up rapidly, and we're expecting even in a week to have access to more testing than we do today.
Yeah, we've been getting conflicting information. I think we had a mom take her daughter into her primary caregiver and was told to go contact somebody else in order to get testing, and I thought it was you go to your primary caregiver to get testing.
You're right. No, the primary care doctor should be the one who can start the process with ADPH of getting the tests, getting the right supplies, and making sure it gets to the right person.
So, Alabama Department of Health said Monday that they'd run 20 tests altogether, 10 through the CDC and 10 through their own lab, which started up late last week. What's your impression of that number of tests, and do you get a sense that they're speeding up any more since then?
Well, I know there's certainly a lot of pressure because patients and doctors are asking for the capacity to do more testing. And we know in states that have more testing, like in Washington state, that the more you test, the more disease you're going to find. So we really think that we're at the stage right now where we would like to test more. There is somewhat of a limited capacity in terms of the number of these tests. We only want to do ones that are verified and proven to be high quality. We don't want to tell people incorrectly that they have coronavirus when they don't, or vice versa. Tell someone that they don't have coronavirus when they do. So there are safety measures in place to make sure that the testing, when it's available, is really high quality.
And is UAB also working on its capacity to do testing?
Yeah, so you may have heard that there is some internal capacity. We are fortunate to be working at a university that's really been at the vanguard of doing antiviral treatment and testing for some of the world. And our labs are developing an in-house PCR-based test. It's not up and going yet, but the team is working hard on that.
What does the timeline look like as far as test results coming back? I know that there's a process when someone gets tested, those get sent somewhere. How does that work?
Yeah, so the process is that the testing is done where the virus would live. So it's usually testing in the back of your nose, the same way a flu test would look like. And sometimes in patients in the hospital, a deep respiratory sample if they're on a ventilator, for example, to get a really good sample to look for virus. The sample has to be put in the right type of media and then sent to ADPH or sent to CDC, which can take from hours to a day. The turnaround time of the PCR itself is a period of days. So we're telling patients that if the testing is being sent off, they're not going to get a result within hours, but they should know within a couple of days.
And so we've been told to use Lysol wipes and things in your office and where you work and wipe down everything, Lysol and everything like that. What would you suggest for people living in homes with maybe different age groups, different immunity systems? How would you suggest like quarantining in that situation and also making sure everything is clean? Is there, I mean, do you put all of your clothes in one place? You know, do you put it immediately in the laundry room? What do you do?
So there's a few different issues to cover there. One is isolation versus quarantine. And isolation is what happens to someone who has symptoms. So if you have a child who has symptoms, who's coughing with a fever, you would isolate them, meaning not let them go to school, isolate them in the house, not have them go out to expose other people. Quarantine is someone who's not sick but may have been exposed. So if you are working in an office where other people have coronavirus, you may be asked to quarantine, feeling fine, to wait 14 days to see if you develop symptoms so you won't then inadvertently expose other people. The question about the different risk levels in the house is a really important one. With most flu-type illnesses, we have this U-shaped epidemic curve where babies and the elderly are the most impacted. And what's really unique about coronavirus so far, as you probably all know, is we're seeing it impact people above 60 with medical conditions the most significantly. So within your household, you can risk stratify based on that. You want to keep yourself healthy so you don't transmit to your mother, to your father, to your grandparents, to older aunts and uncles or neighbors who are in that age group. As far as cleaning, this is a droplet spread cold virus. So when someone coughs or sneezes or sings, you can have droplets that hang out in the air and eventually will land on any flat surfaces. So it's things that we touch. It's the telephone, it's the doorknob, it's the cell phone, it's the TV controller. Those are the things that you want to make sure to clean carefully. Anything your hands are touching is what you want to clean, not the drapes. You know, you don't have to do a full house clean every 12 hours, but if you can clean the surfaces with Lysol or with something that has a good alcohol level, that's how you can kill some of these germs.
Okay, so from what you just said, though, I understand that if you're in a household with people above 60, that's the age group you want to be most concerned about, not necessarily children?
Well, I mean, we think that children may be carriers, so it's not that children cannot get the illness, but the mortality rate in children is incredibly low. So your child may be having mild symptoms and still could give the illness to your grandmother or your grandfather or your aunts and uncles. So in terms of thinking about risk, the older people above 60 with medical conditions is definitely who you want to think about. There are other patients, stem cell transplant patients, cancer chemotherapy patients. I take care of HIV patients. All of those patients have a reduced immune system, and we think they're probably also going to be at risk. So those are the people you want to be most careful about having them not go into public if they can avoid it, not get on plane flights if they can avoid it, anything to reduce that risk of exposure. Good questions.
From what you were saying about it spreading, it's droplet oriented, so it's not going to be in the air, like, necessarily?
Yeah, so there's a lot of debate about this right now in infectious disease and in epidemiology, the distinction between droplet transmission and airborne transmission. We tend to think of airborne transmission as something like tuberculosis, which is really tiny droplets, that if I have tuberculosis and I cough, it can hang in the air for 2 hours, where I breathe it in deep into my lungs, but it doesn't fall as quickly. The droplet-like illnesses, which is what the cold viruses are, tend to be coughed or sneezed out and fall much more quickly, if that makes sense. We are recommending droplet precautions for people in the hospital, but part of that has to do with the fact that we're doing procedures like intubating and medical procedures that aerosolize those droplets and turn it from a bigger droplet size form into the tiny airborne size form.
So how long can the viruses live in the droplets on surfaces?
So what we know for flu virus is it's 2 to 7 hours. It's looking like it's about the same for coronavirus. Studies are ongoing. Like anything else, if you're coughing into like a wet Kleenex, that's a place that a virus can live longer than if it's a dry surface that's cleaned frequently.
So if somebody is, say, traveling and they're getting on an airplane and they're worried about breathing the air in this airplane, is that a valid concern?
So anyone going anywhere in a group of people defined as more than 100, more than 200, it depends where you want to draw that line, should be concerned about potentially getting an illness from someone who is asymptomatic or has minimal symptoms. What you can do to protect yourself is not put yourself in that situation, not go to large group settings, try to avoid being exposed to anyone who's sick. And then deciding for your own self, based on your medical history and based on the people that you live with in your house, how comfortable you are in the day-to-day activities that we all do, going to the grocery store and things like that. I think as this epidemic progresses and we start to see more and more cases, I think you'll see people curtail their activities based on what we're all seeing. So it's difficult now to tell people in Alabama you should make drastic changes to your life and not leave your bedroom, because we don't have cases that are confirmed yet. But if we get to the point where we do have a lot of confirmed cases, where we have a lot of people who are very sick, that's when the story's going to change. And I know that you'll all be on top of that.
And does the WHO's declaration of a pandemic today change anything for you at UAB?
It does not. It does not. You know, I think it's sort of many people think that the announcement should have been made in the past because there were cases around the world increasing in number. It changes things in terms of WHO, preparedness planning and getting resources, especially to low and middle income countries where they're less prepared than we are in the US. But honestly, for us in Alabama, it doesn't make any difference.
Can you talk about people in that middle age range that it doesn't necessarily affect, or they're not dying, but they could possibly pass it on to someone who it could affect, like older people and younger people? Should that be a concern for those people who aren't necessarily directly affected?
Yeah, so I think the numbers that are useful in general is what we're seeing for coronavirus is about 80% of people who have illness will be mildly symptomatic. Most of those mildly symptomatic people will be in the younger age group, but it's possible for some older people also to have mild symptoms. About 15% of people will have more severe, moderate illness, needing some type of medical care, maybe an ER visit, maybe a short hospitalization. And 5% are going to need ICU level care. So that is how we plan for the numbers we expect to see in Alabama, at UAB and in other hospitals. But when you look at the age breakdown of those, again, that 5% who needs ICU level care, we expect mostly to be people above 60 with medical conditions. Where did that person get the coronavirus from is what you're trying to prevent. If that person is living in your household and you know that they're in that high-risk group, you want to try to prevent yourself from getting sick, even if you have minimal symptoms, because of your ability to transmit to someone else.
And I'm not sure if you said somebody else would be able to answer this, but talking in terms of the hospital and how they will prepare for a large number of people coming in, because I know most hospitals operate at like 80 to 90% capacity.
Right.
What would
Right.
we do if
Right.
we saw like a huge influx and needed those beds?
So that's exactly the type of thing that our hospital emergency preparedness plan is written for. There are teams of people in infection control, in the emergency room, in the surgical suite who plan for events like this. And what they say is if we have this 15% of people who need hospitalization and 5% who need ICU level care, how many beds do we need? How many ventilators do we need? You sort of make your checklist of all of these things that you expect to need in preparedness. So I can tell you this team is meeting regularly and they know each other very well at this point, and they're changing the plans every 12 to 24 hours based on new data that's coming in. And the team is well equipped. There are a lot of ventilators and there's a lot of critical care doctors here, obviously a big group of well-trained pediatricians, adult doctors, geriatricians who know how to manage these types of diseases. So this is what they've been preparing for in a way.
So as it stands right now, you're not seeing a huge influx of people coming in just with sniffles and stuff just to be checked?
We're not. We are in the middle of the flu season. So in my clinic, for example, I'm continuing to diagnose people with flu this week. They have fever and cough, and I do the flu test, and the flu test is positive. So that confounds things a little bit. Some of the people coming into the ER may be thinking coronavirus, but actually have influenza. But no, we are, every winter, every February and March, people have sniffles and runny nose, and they call their PCP about that. We're not seeing a huge increase in that number.
Do we know if you did test positive, if you have coronavirus, could you also test positive for flu if you took a flu test?
So that's part of the reason of wanting this good quality test. We don't want cross-reactivity between the flu virus and coronavirus. In other countries, the rate of co-infection with both of these is incredibly low. So we don't think that the likelihood of having both is very high. The flu test we have is very good just at detecting flu, and this coronavirus test that we're working on getting better access to, it's very good just at coronavirus. So there shouldn't be any confusion about what you have. The one point that's worth bringing up is we do a viral respiratory panel in the hospital on patients who have fever and cough. That respiratory panel includes a whole number of common respiratory viruses. One of them is coronavirus because that's the cold virus, but it's not coronavirus 19. So that if someone was to get an ER test, for example, and see a negative coronavirus, that's not actually COVID-19. It's the coronavirus that usually circulates. Have I exhausted your questions?
All right, I think that's all for the medical questions, and we'll have Dr. Benoit, the provost, come and answer any campus-related questions.
Thanks.
Yeah, I'm curious whether, given that y'all are in such close proximity to the hospital, whether the campus is making any advanced plans to how they would handle a case of coronavirus, or any plans right now to move campus or classes online or anything of that nature?
So there's several parts to that question. So let me start about the planning. So there's an emergency planning group that has been meeting regularly to talk about overall planning for the campus. Each one of the schools has also been asked to work on filling out and tweaking their business continuity plans and for various kinds of scenarios that could potentially happen. And we've done a lot of planning if the campus would need to move to remote offerings of classes. So today, for example, we put a website up that has a lot of resources for faculty, both for using Canvas, which is our learning management system, as well as for using some low-tech options if we needed to move classes away from in-person classes into more remotely offered classes. So all of those plans are in progress.
Any suggestions for students heading out for spring break? Or you'll-
We'll be providing some guidance about that very quickly.
Can you give us any sense of what the guidance will be, telling them not to travel to certain parts of the U.S. or any of that?
So there's been previous guidance about travel, about international travel, and looking at impacted areas and thinking about the risks of doing any kind of international travel and what might happen if they came back from an area that was infected. One of the things that was said earlier, I noticed, is that this is an incredibly fluid situation, and so things are changing hour by hour, and so a country that they might feel would be safe to go to right now could become unsafe while they were on break. And so we want them to give some serious thought to where they're traveling. The same thing would be true of various domestic locations. We know, if you look at the CDC map, that we have some hot spots within the US right now. And so thinking about whether or not those are good places to travel also need to be part of their consideration.
Is there any guidance for students just on a daily basis? I mean, wipe down your desks when you get out
Yes.
of class kind of
Yes,
thing?
so the same sort of guidance you just heard about. So washing your hands for 20 seconds, making sure that you cover coughs, that you, there are places where you don't need to go that have large gatherings, you might want to think about whether or not you want to go to those at this point in time. All of those are the standard guidance. They're being given not just to students, but to faculty and staff as well. And then the cleaning. So you heard earlier, you know, using Lysol or some disinfectant on commonly used areas, especially where you're touching with your hands, like your telephone, your keyboards, those kinds of things. So we've reiterated that advice to them as well.
Is UAB doing any additional cleaning? Have y'all changed the cleanings? I know y'all did before. Have you changed anything since then?
We are doing the same thing. We have heightened protocols for cleaning so that we're cleaning more in order, especially in those particular areas, because we know those are places where those droplets are likely to land and to survive for a while. And so that's been enhanced across the campus.
What about any sporting events? We know that they've talked about playing certain games without crowds or anything. Is that going to be something that you're looking at UAB?
We are always planning about that. We're thinking, for example, we know that we had a tennis team that was going out for an optional tournament out in California, and they're no longer going on that tournament. We've canceled some other kinds of trips across the campus as well because they're in those largely impacted areas because we don't want to expose our students to potentially increased risks. And again, happens on a day-by-day basis, and we'll continue to make judgments about that as more events unroll.
Is anything they canceled today?
Let me think. No, there are some things yesterday. There are some things that we're talking about today, but they haven't been canceled yet. We did also send out advice about what causes an event to be canceled or what causes us no longer to bring visitors into campus, the kinds of things that should be considered as we think about that. So what would the size of the event be? Where is this person coming from? All kinds of questions to sort of think about what is the level of risk to try to minimize that as much as possible.